When the music stops, please find a seat.
We had to whistle the Jeopardy song.
That was one. Welcome to the February 24th meeting of the Health Human Services Oversight Committee. I do not believe that we have a quorum, so I would suggest we dispense until next time with the reading of the minutes, since we can't vote on them. One of the great features of this.
Mr. Chair,
Yes, sir.
is there just 10 of us on the committee? And are there 5 of us present? 5 is not a quorum. You need 6 for a quorum, if the committee is 10. Okay.
Sorry, Mr. Chair.
Here we go. You heard you.
I was testifying.
Just must have heard you, a representative.
I answered.
Since we have a quorum, please take the minutes from the February 3rd meeting, look over them very quickly to see if there are any errors. We're reading over the minutes from last time to see if we will approve them. Your comment, Representative Edwards.
Okay, it's not that big a deal, I don't think, but before I left that day, I think we were on the Child Fatality Review Committee, and I thought we had a decent discussion, as short as it was, regarding doctors giving advice on firearms. Do you think that that's covered adequately in the first paragraph? The director gave a report on suicides, and what the committee has found, the results indicate suicide by hanging firearms.
What would you propose we add as a sentence that would,
I'd say that we opened up a cautionary note that clinicians ought to be judicious in when they counsel patients and ask questions of their pediatric patients regarding gun possession in the house.
Would you care to attribute that to somebody? Because I didn't participate in that sentiment, and I don't want to be associated with it.
That was me.
Okay.
That was definitely me.
If that's attached to your name, then I have no objection at all to adding it to the minutes.
Right. And later when I talked to Ms. Tilley, she had a great reason for why it was important. If the child is suicidal, for example, it's a perfectly great conversation to have. But still, the clinician and patient relationship is really relying on trust, and some questions ought not to be asked.
anything else?
Yes.
Representative King.
Can you repeat how you'd like that said in the minutes so I can catch it?
If you'll allow me, I can't talk and think, but the words jump out of my fingertips when I'm on a keyboard.
Would you accept a cautionary note was raised that clinicians be judicious in asking gun possession questions in their young patients, plural, possessive home?
No, because that attributes that sentiment to all members of the committee, and I don't share them.
Representative asked. Representative Edwards asked.
I don't think he asked. I think he stated.
Did you ask or state?
Because I was leaving, I did state it, and I think it ended up in a conversation after I left.
A cautionary note that clinicians be judicious in asking gun possession questions of their young patients' homes, Representative Edwards stated. Okay. Anything else in the minutes? Seeing, hearing nothing else, could I have a motion to approve the minutes with that
So-
addition?
Second.
Representative McDonald moves, Representative Edwards second. All in favor?
Aye.
Opposed? Thank you. The minutes are accepted. And now the reason we all drive here, the update from the commissioner. Lessons from Lori. Now in its third and great year.
Good morning. That's quite a expectation to live up to. Good morning, committee. I have a pretty robust update this morning via channeling Director Henry Littman from our Medicaid program. We'll be talking about the unwind coverage as well as covering some of the adult dental, the recent legislation, and some rate discussion. So that's a pretty robust discussion. I'm going to have Henry and Karen come up to start to talk about the unwind of the public health emergency.
Though this is not a good place to unwind, would love to have you come up.
Good morning again, Henry Littman, Medicaid Director for the record.
Good morning. My name is Karen Hebert. I'm the Director for the Division of Economic Stability. Thank you.
So I just open up and just sort of set where we are. As you know, the Medicaid program today has the largest enrollment, I think, ever in the history of the program because of the continuous coverage requirements, first under the federal public health emergency and secondarily under the Consolidated Appropriation Act, which was passed at the end of the year. That act bifurcates continuous enrollment from the public health emergency and defines a date certain in which states can begin to unwind. I'm happy to report that before states can actually initiate this activity, they have to go through a process of sharing with CMS, Centers for Medicaid Medicare Services, that they have the systems and things in place in order to do this. That states could begin at the earliest disenrolling people April 1st. I think New Hampshire is in the top quartile in being able to begin early, and that many states are going to need mitigation plans before they can begin. So I think in terms of ready, set, go, in terms of being able to begin the process, we're positioned and actually are executing as we're speaking today. The process is starting to move. And just in terms of the slide deck, I'm not going to try to cover every single slide in this deck, and I think you just kind of run to slide 5, gives you the state of enrollment as of January 30th. Let everybody catch up with, make sure that the number's kind of small on the page. I'm sorry if you Everybody's with me at this point. The standard Medicaid program has grown by about 20% since the end of February of 19, basically the effective beginning of when the continuous enrollment began in March. And the Granted Advantage program has grown 86%. In total, the whole program has grown by almost 40%, 39%. We're probably, if you look at our enrollment today, we're just over 250,000. So just on the bottom of slide 6, there's some important definitions here. Today, the continuous enrollment is protecting just under 102,000 individuals. Were it not for the continuous enrollment, would no longer likely be on the program. They sort of fall into two groups of people. One is the group of people that were it not for the continuous enrollment and not completing their eligibility paperwork would have been disenrolled, and that's about now have a slide coming ahead on that. That's about 73,000 people almost. And then there's a group called pending and eligible, people who did complete their redetermination and currently are protected in the sense that they're no longer eligible but are protected by continuous enrollment. So they may be over income, as an example. So if you turn to the next page of slides.
Mr. Chairman, can I ask a question? Or
Yes, a question.
would you mind taking a question? Would you prefer to wait till you finished?
I'm happy to go however the committee would
Okay.
like.
So am I right in thinking that the pending and eligible are the people who we are unwinding or
No,
that we will
it-
be unwinding first, or?
I think I'll get to that if you give me
Okay,
1 second.
I'll hold it. Thank you.
So just to get the population for you in terms of that, what I just sort of described is at the top of the page is described as in the counting individuals. If you look on opposite side, it's counted as households. Our approach to working this is actually to do it by household, because why make a household go through 3 or 4 different redetermination processes? To do it as a group. On the bottom, slide 8, which is sort of the purple and green and blue colored slide, it's basically who of that 101,000, where do they exist? And as you might expect, because the largest growth was in the Granted Advantage program, the largest group of people that have had a protected status are people in the Medicaid expansion. The concerning group for us, I think, is the children, the almost 35,000 children, where we've done significant outreach, and actually, Karen's team, maybe Karen, you can speak to all the outreach that you've done, but some states stopped doing regular work. We never did, and we got over 32,000 people to voluntarily complete their redeterminations, and now over 2,400 people have told us, based on proactive asking, if you will, do you need Medicaid coverage anymore? And people have come forward and said, we've got something else. We don't need it anymore. So we've been able to deal with over 34,000 cases, which that 102,000 would have been almost 135,000, 136,000 otherwise. Karen, you might share a little bit about what your team has done, and they've done a great job.
Sure. I'm just going to move this a little bit. Good morning. So this for the department, I oversee the Bureau of Family Assistance as one of the areas of the division, and that contains all of the staff who conduct the eligibility processing. So they receive applications, they receive renewal applications, and process all the verification documents for folks to determine their eligibility. So that particular, it's a large group of staff. They are in all of our district offices across the state. And I will say that I'm incredibly proud of them for the work that they are doing to get ready for this. This is all about operational readiness because we've never done this before. This is unprecedented volume of work that we are anticipating from our constituents, from our citizenry, Medicaid beneficiaries who we've been trying a number of strategies to reach out to each of these individuals to make sure that they understand what's happening during the continuous enrollment process, but even more so now that we have a date where that continuous enrollment is ending. So the outreach that we've conducted, we've reached, I believe, over 40,000 families that our staff have reached out to make sure that they are aware of what they need to do, that they understand the instructions. We've been working with a number of the providers as well across the state. We have office hours, if you will, for them, a number of them that they can contact us to talk about the clients that we have in common to help them. So we're actually having a lot of the provider groups help us as well to do a lot of this outreach because we can't do it alone. So we've really been partnering significantly with those provider groups to make sure that they can help us do a lot of this outreach. We've also been putting together some new workload distribution plans to end up processing as much as we can, as quickly as we can. This is all about capacity and how do we increase that capacity to make sure that nobody, or as very few possible people as possible, experience any kind of gap in coverage or lose their coverage. We don't want people to learn or figure this out while they're in the checkout line at the doctor's office or the pharmacy. So these are concerns that we have had all along in trying to prepare for this process, for this volume. We've done a lot of simulated activities as well, just to test our own readiness, and those have been going very, very well.
We've also engaged the managed care organizations in this, and part of what we've done is we've given them lists of where they have a patient relationship, and where like a mental health center, or a federally qualified health center, or an area agency, a hospital, what have you, we give them a list of their patients with what their redetermination date is and what type of things are they missing to complete their redetermination. And we've been doing this for going on 2 years now, trying to get people to do it voluntarily in advance, as well as now, and I'll get into this in a moment here. Part of the process that states have to follow to, if you go to top of next page, top of that slide 11 on the right-hand corner, is that to earn the extra federal matching percentage, the federal medical assistance, FMAP as we call it, which up to this point, the additional federal monies we've received has allowed us to cover the cost of the extra enrollment. So the state hasn't had to, if you will, incur extra general funds to support the program. But that extra money is going to be phased down, and which is why, because New Hampshire, compared to some states, like take a state like New Mexico as an example, they have a much higher federal matching percentage because their poverty level is among the highest in the country. So states that are more, well, New Hampshire has a good economy, right, and some good wage here, that we're at the minimum FMAP for standard Medicaid, which is 50%. All states get the 90% for the expansion population. But in order to actually draw these funds, you have to follow somewhat of a guidance. And the guidance is intended to return to normal operations in the sense of that we don't want a big bolus of redeterminations all in 1 month that we're not going to be able to handle in future years. They're trying to get states to get back to, having a normal distribution. So what we had to do is, of those people, that 73,000 roughly of individuals, we had to map out new redetermination dates for them, so that if you go to the bottom of slide 14, is a sort of the spread of how we get back to normal within a year's time. And I'm going to talk a little bit more about this on a subsequent slide, but basically this is part of our plan that we had to have approved. It's showing that we had a plan to get back to normal in terms of a reasonable distribution, as well as followed other things like making sure that we followed the normal noticing, the normal decisions, giving the right of appeal, all that kind of thing, process, procedural things that people are entitled to for rights. And I'll jump over to the top of, I'll skip the next page because we kind of talked through that. The slide titled "Percent of Population with No Provider Payments." The way, and then the monthly distribution. These are really two important slides if you to understand kind of what's going on. So when we needed to distribute the population over a 1/9 basis, we said, what's the way to go about this so that we did it sort of on a risk basis. Some states are just doing it, just across the board. We try to take an additional level of sensitivity, both from a financial and a clinical perspective. So what we did is we analyzed all our enrollment and looked at trying to put first those people who haven't used healthcare very much or at all. And so they're more likely to not be harmed by being disenrolled versus, for example, someone who's a hemophiliac or has other serious medical conditions that moving those people further out into the unwind because they're most likely to qualify, and a gap in healthcare coverage is more likely to do harm to them. And then this all falls down to this what is our estimated plan of how this is all going to work out.
Chair recognizes Representative Edwards with a question.
Thank you, Mr. Chair. Thank you, Mr. Lippman. We're going to hit this in more detail on Division 3, so I'm not looking for a detailed answer here. But I can't help but to think as you're going through this, that one, this is tremendous work. But then I get into wondering about the manpower required to be planning this and executing this, and the availability of any IT system support that's making it easier or harder for you. And then that leads me into thinking, well, what about the MCOs? How much are the MCOs having to invest manpower and time into this as well? And I guess the kind of answer I'm looking for is, is this really pushing your organization, your manpower, to where you're largely maxed out on your capacity to manage this much change, or do you feel like you are doing this easily in stride?
So I guess it's sort of a two-part answer. I think we've been working this since July of 2020. We've been planning, and fortunately, a lot of the investments that the state had previously made in its eligibility system, that the reason we're sort of ready to begin anyways is that we leverage off what we've had. I think we're in a good shape. What's the unknown, for example, is like the appeal process. How many people are going to appeal? Are we going to get? Is there going to be a place where we, get held up a little bit because of people just taking advantage of appeal rights when there may not be any ability for them to maintain coverage? So I guess our answer up to this point, I think it's been, stressed us, but I think that we've tried to manage this so that we don't get overwhelmed, which is to say, since we've never done something this big, we do have some concerns that we could, as we, particularly at the beginning when we're moving a lot of people off, do we have the workforce to handle all the incoming information? But we've tried to beef up for that.
Yeah, if I may.
Please.
Thank you for the question. So there has been a lot of concern about our capacity to be able to process what's coming. So we've been working very hard at coming up with a number of different strategies to try to ensure that we could process this as quickly as we possibly can and as effectively as we can. We've been bringing in, for example, individuals who still work for the department, but perhaps were formerly an eligibility worker to work an overtime project so that we are able to make use of other resources in the department that are willing to help us with these efforts. We have strategies with respect to new hires, where we would train them first on how to conduct redeterminations so that they can focus solely on that. We've redistributed caseloads so that we focus on this protected population within one particular office, if you will. So different ways that we're trying to increase our own capacity. It also includes the procurement of a call center. So right now we have a current temporary call center, which contract expires in June. Terrible timing for that. But we've been procuring a new call center that we're adding a lot of functionality to, including being able to conduct some of the outreach and other administrative processes for us. And we're wanting to stand that up by July 1st so that they are ready to answer the phone by July 1st. That process is going well. Staff have been, as I said earlier, I'm very proud of them, having really facing this with the right attitude, that they've got this. That makes all the difference in the world. So I'm confident in them, even though we're a little bit apprehensive of not knowing quite what to expect. And we're going to monitor and evaluate this constantly, and just see how it goes, and where we may be able to make some adjustments.
Follow up?
Oh, so I appreciate all of that. And I'm oversimplifying this. I'm really trying to understand, is the capacity that you have with all your planning and everything anticipated to be pegged out, or do you think you have additional flexibility in your system for some other exigency to pop up?
So I think that, we try to keep some strategies in the back pocket, if you will. Will they be effective? It's a bit unknown. This is really unpredictable. So I can't say that, we are solid on how this is going to go. I can tell you that we'll just do the best that we can.
Representative Weber?
Could I ask the same question a different way? Do you feel you are adequately staffed right now or understaffed right now, for both what you know today and going forward into the future?
I believe that we are. I think if I were to diagnose where I think we are concerned where we may need some more resources, and we're working on putting together a plan there, because it's sort of where's our weak spot is on the appeals and what we can do to minimize, in some cases, there's no basis for appealing. So can we do a pre-resolution so that, we're not tying things up? But I do think that, part of how all the pre-work that we've done, in other words, all the voluntary activity that we've been able to get, the 32,000 people that did their redetermination, the 2,400 people that have already let us know, and there are going to be more who will let us know. We don't have to go through a full redetermination with that. Mm-hmm. The other thing I'd point out is that the approximately 29,000 individuals who have completed a redetermination that are sort of front-loaded because we know they're ineligible, they'll have a chance to, we'll give them a notice and they'll have a chance to update it, but based on what we have for information, we're not expecting them, they don't have to go through a full redetermination process. They go through a process that will be less. And so again, having done all that work with that group, it's not 100,000 plus that we need to do a full redetermination on. It's a smaller group. It's that 73,000. Then when you do it at a household level, we're back down to 47,000 households, which is different than 73,000 people, because there's sort of a case head and we can work it that way. I feel like we're as prepared as any state is out there, if not more. Again, I think the area that I feel we have some to strengthen, and we're working on it as we speak, is getting ready for that pre-resolution and being able to handle appeal volume if it materializes.
I think just spreading out the distribution over this, 12-month period is going to make a tremendous difference. So that is a really helpful part of this plan that CMS had put together for states, because if we had to do it all at once, I would definitely have more concerns. But spreading it out and strategically determining each month which group we would look at is going to make a tremendous difference for us.
Representative McDonald.
Good morning. I know historically, having worked for the department, there's usually a number of vacant positions in every division. Do you have a number of them in yours, and how many if you do?
My-
Maybe that's a tough,
You got the
maybe that's
bigger
an
group.
unfair question. I apologize if it is.
No, that's okay. I've been watching the vacancy rate, certainly in light of, well, regularly, but in light of this as well. So for eligibility staff right now, it is at a 22% vacancy rate.
And that they would determine the eligibility for Medicaid and all that, that thing. Okay, thank you.
In my area, I think I'm about a 32% vacancy rate, but in terms of this issue, probably my deputy director left to take another position outside of government, who was spearheading this for us. We have been working very closely with, Deb Sorley, who's part of Karen's team, is taking that slice of the pie in terms of standing up and keeping that work going. And we haven't lost a step with her stepping into supporting us. So we had some redundancy there.
Follow up.
So you said you have a 32% vacancy rate in the Medicaid division? Or-
Yes.
Okay, good. Thank you.
So if I could just draw your attention to the bottom slide below the percent of population, says monthly distribution of individuals estimated. If I take you to the far right of the top chart, I'm sorry the numbers are small here, but we'll send it to you electronically so you can increase it on a PDF. But if you notice, like 3 lines from the bottom, the 101,798, that was the same number you saw earlier on when there were the 3 boxes. And then the numbers above that, the 28,996 is again the same number when you looked at individuals. And the 72,802, which I've been rounding off to 73,000, is the same number you saw previously. And so what we're expecting overall, based on experience, is that about just under 59,000 people who are currently in that protected group will likely not remain eligible. And so if you take 60,000 roughly from where we are in terms of current enrollment, that's going to bring us below 200,000. And then we have other individuals who are going through their normal distribution, and the normal workload of about 11,000 redeterminations a month. We feel like that we're going to probably within a year's time, the 95,000 in Granite Advantage is going to look more like 64,000, and as we go through another year, we'll get back to, I think, more where we were pre-pandemic, if you will, in the 50,000s, probably mid to upper, depends on the economy, how many people, poverty levels were just increased by the federal government. And all these numbers reflect running the latest poverty numbers. There were about 1,700 people who otherwise were ineligible that benefited from the new poverty levels that increased about 8%. So a lot of the rest of this is about what we've been doing again, I think when you talked about earlier, Karen, how, people have bought into what we're doing, what we really try to sort of message internally is, we don't want anybody to lose coverage who shouldn't lose coverage, right? And those that aren't going to be able to remain on, we want to find if there's a different source that they can get coverage, for example, the exchange, we want to make sure that they get connected to that. Or if they're aging out of the program, make sure they get connected to Medicare. And so, again, showing some initiative and leadership, I think, in the country. We actually were the first state to approach it's called SCIO, which is an abbreviation for the part of Health and Human Services that oversees the operation of the exchanges, both from the insurance companies and looking for consumer protection. So, for example, someone who was over income who did nothing with their application, just let it die off, ordinarily nothing would happen to them. They would disappear into the ether. We worked actually to develop an exchange. So someone may ordinarily apply for Medicaid or ordinarily apply for exchange cover directly. If they qualify for one, for example, exchange, and not Medicaid, we send it to SOCIO, and if in reverse, they'll send someone who may qualify for Medicaid. But these people who would otherwise, if you kind of think of a dead letter box, if you will, if no one does anything with their application who's over income, nothing happens. And what we've worked on is a process to exchange that information back to them so that they can work with the with the navigators and however they want to do it to make sure that they're given the opportunity to apply for coverage in other mechanisms. One of the big messaging things that has just come out of the Consolidated Appropriation Act is for Medicare individuals, and we do have people that are aging out of Medicaid, that they have an open enrollment period that's actually not just associated with the unwind, but permanently now, that if you lose Medicaid in your Medicare level, you can have an open enrollment period for 6 months. But what we're going to try to encourage people to do, because it's not good for the New Hampshire insurance market or for the individual, don't wait for there to be a gap in coverage before you do something. People who are on Medicaid will have an opportunity to apply for exchange coverage in a period that's going to be a one-time period between April 1 and July of 24 to apply for exchange coverage. Again, looking at it for the benefit of the individual. If you get in a car accident and you don't have coverage, you're going to be in a hurting place financially. This new open enrollment period allows someone, if they know they're going to lose coverage, to 60 days in advance to apply, get it all situated so they have 0 days of non-coverage. We've been working with the insurance department. We've been conversing with the large insurers in the state, that like Anthem and Harvard Community Health Plan, about the population that's going to be coming off that may be their future customers, and making sure that they understand what's going on. I'm talking to the New Hampshire Health Plan, which does the high-risk stuff, to make sure that this transition not just works for Medicaid, but try to make it work for the insurance department and for individuals and the private market. I'm trying to be sensitive to time here. There's some other information about, like, our noticing on slide 27. We went from what was just, we started off with pink letters to individuals. So when we were trying to get them to voluntarily do it, sort of a friendly kind of, it's a good thing to do on your own behalf, pre-plan. And now we've converted to yellow letters messaging. And the detail that we've had to think about is, for example, there's a national paper shortage, and making sure that we've got supplies of paper, and making sure simple things like, will our mail machine handle the envelope that we intend to use? Because we had an example where it didn't. So just logistics, getting all those things, and making sure our mailroom's situated. We have about is it close to 60% now of our enrollment have an electronic mechanism. So they have an online account, so we save postage and what have you, and we're able to communicate that way. I guess maybe moving to the slide 32 and 33, maybe a good place to go here. There'll be certain federal reporting requirements that were embedded in the Consolidated Appropriation Act, and slide 32 and 33 outline them and kind of our status at the end of January in terms of being able to handle all those things, and we believe that we are. But on top of that, the bottom of 34 going on to 35 is actually using our technology. We're going to have a much more robust system of being able to reporting on metrics because there's going to be a lot of public interest in this, and we're going to want to know, are there certain geographic areas or particular communities where the disenrollment is higher than you would expect it to be, so that we can, take appropriate actions. And let me just stop there. I know there's other things we want to cover with you, but I think we hit the highlights that you as legislators would probably be interested in, and happy if you want us to come back and give reports on this as we go along to do so.
Representative McDonald.
Thank you, and I'm sure covered somewhere, but MSP under Medicaid individuals by eligibility category, what does MSP stand for?
The Medicare secondary plans, the people who are like our duals.
Oh, okay. They have another insurance in addition to Medicaid, you mean?
Yes.
Okay.
The poor elderly, if you will.
Representative Edwards.
Thank you, Mr. Chair. So what I think I heard you both say is you have all the manpower that you need to do this program, and when it's done in a year, you'll have excess capacity.
Sure.
I don't think you heard us say that exactly.
I know, because I couldn't get you to answer the question directly.
Well, I mean, I think to be, not to be disrespectful or whatever. I mean, we've done the best planning we can. We know that, turnover issues that we can experience of a key person, we're not necessarily deep in different areas, but I think we're ready to go. I think the other thing too is there's been lessons learned in planning for this that I think we're going to carry forward. And also, there's only so hard you can push. Her eligibility team are going to be asked to do almost 50% increase in their workload, and is that sustainable without pushing people out because they get burnt out? I think is another concern.
Those last three sentences were those. That's what I was looking for.
Okay, thank you.
You're going to bust your butt for a year working 50% extra capacity, and then you're worried about burnout during the course of the next year.
Sure, I don't want to lose any more people.
Right. Okay. No,
So, yes.
that was the answer I was looking for. So thank you.
Right.
Any other questions?
Well, and just to follow up on
Representative,
that,
yes.
if I may. And at that point, you're still going to have the rolling ongoing determinations. And although you may have fewer people coming off, you still have whatever the current volume of applications to come on that you're going to have to deal with.
Yes, so there's a lot more work that we're doing besides Medicaid for eligibility of all the other eligibility programs that, of course, there's a concern of what's going to get neglected because of Medicaid unwind, if anything's going to get neglected. So we can only work with what we have, and then trying to be prepared for worst case scenario, if you will. I mean, that's what this has been all about.
But I think, if I may follow up, I think
Yes.
Representative Edwards and I are both trying to get at the same thing. And I think that thing is, if you think you're going to need more people, you need to say so really loudly and clearly to him, because that's where the money comes from. And I'm sorry if I'm putting words in your mouth and that isn't what you meant, but that's sort of what I was hearing.
Thank you. Year 6 continues with me learning from you. I need to figure out how to just say, tell me if you need more money. That's really where I was going.
And I also assume, or I will just say from my perspective, although I want you to have the people you need if we can find them, which is the whole other issue, I also don't want to throw money at a problem if it's not going to be useful money thrown usefully at a problem. But I also, Mr. Chairman, if I would love to hear an update in maybe not a month, but maybe 3 months or at whatever interval the committee deems best, because the thing that I want to keep my eye on, as well as whether you have reached the end of your elasticity and something's going to snap, but I'm hearing your concern about the appeals process, and I think we want to keep our eye really carefully on that. So I don't know what the best reporting schedule is. My thought would be 3 months, but
I've already asked Mr. Lippman to come back every month that we meet, even if it's a brief report or
Okay.
sometimes a long report. And he says this is his favorite group of people in all of Concord. So, of course, he'll come back.
don't you have to say that?
No,
thank
he
you.
doesn't
I
have
don't-
to. He graciously did.
Oh, okay. Thank you.
I would say also too that, we've gone out and talked to like the congressional office, the governor's office in terms of the people who might get constituent issues. And we do want to, sometimes there's a lot of unique circumstances, and sometimes I think we've tried to plan for every contingency of those unique circumstances. But, if you hear of constituents that are having a problem or something's not working right, we want to hear about it. So you can help us in that regard, and appreciate it.
Absolutely.
Is it likely you're going to be coming back a little bit later this morning and talk to us about teeth?
About what? I'm sorry.
Dental.
Oh,
I have dental.
Yeah, but just before noon. Okay.
May I just add?
You may.
The question on the staffing, and I heard that you were trying to ask this question, and Karen's being very gracious in her answer, but we are 22% in aggregate, right? So in Karen's and Henry trumps Karen with the 32 to the 22, right? Our nurses trumpet at 64%. We're robbing Peter to pay Paul to do this work, right? So we're paying overtime, we're doing comp time. I'm pulling people that do other tasks, have done it in the past to come do that. So we have so many open positions. So it's not about adding positions necessarily. And part of our goal is to try to fill those positions. And as we do, we burn out the people doing the 50% more, right? So I guess the ask would be in terms of understanding the process and the work that we're doing, and that we may fall behind. We may have complaints, but we're doing what we can with the resources that we have. So I just, Karen's getting very creative with how we do that. But at the end of the day, I do worry that we're going to be 32% at the end of this year. So I just wanted to add that.
The previous Lori told me about a job fair and around and all. How did that work out?
We're constantly doing job fairs. I mean, we
Okay.
just had
Still,
an item approved to get some additional software tools. So recruitment is constant, innovation is constant, going to schools. I mean, never mind job fairs. I mean, we're on the street corner. I mean, we're everywhere we can get to ask people to come work for us. I'm being sarcastic with the street corner. My point is we're everywhere. To try
That
to
does
get
explain a sign I saw, though. Okay.
I was going to talk to you about the dress code on the street corner, but
I was going to ask how your pay compared with legislative salary, but
And that's a real, I'll be honest with you, wages are a real challenge, and we're trying through our Department of Administrative Services to get a new system up that will bring us up to some levels. But unfortunately, that takes a little bit of time, and that's time that's not gonna impact from a year. This is happening now. Sure. So, thank you.
Welcome.
And if you still have time for us, I have some.
We have some time.
Have the dental update.
Uh-huh.
could I just ask one more question before you do the dental update?
Sure.
I keep wrestling with this problem of workforce shortages, which I see everywhere I go. That's no news to anybody in this room. I wonder if some concept, and this is for a different committee other than the one I normally sit on, but I keep hearing, you've got a 22% gap. And these are positions that are currently funded. They're just not filled. And I keep wondering if that couldn't be shifted somehow via the budget or some other mechanism or reclassification or something to fewer funded positions, but having those positions funded at a higher level using the funding that's already allocated. And this is clearly a question coming from somebody who doesn't work with this all of the time. And I just throw it out there if that's something you think about or And I don't desperately need an answer. I just wanted to kind of throw it out there because it sounds like if we could get you by offering higher wages for the positions that are open to a 10% gap, that might take some of the strain off at least.
Yeah, it's a great question. It's a strategy that we've considered to, like, even temporary enhancements to those positions while you're doing some of this work for some of the staff. The reclassification system that DAS is working on is doing that, is elevating up eligibility positions. They're probably one of the lowest paid positions that we have with the most complex work that needs to get done. It's not necessarily easy to determine eligibility. There's a skill set there. So yeah, we are working on that for sure.
Okay, great.
Thank you.
Thank you.
So the next report we have is on the adult dental benefit, and we're just a little bit over a month away when we're looking to begin. We have to get as part of the legislative mandate to have the denture benefit available only to the waiver population and people in nursing homes, as well as the cost sharing. We had to do a number of different waivers. They're all in motion. We've feel in a good place that we're going to get them in place by the end of March so that we can begin April 1st. That being said, I think our biggest challenge is sort of the network development, and that's we're focusing on that. We've had some good wins there in terms of, in particular, oral surgery has been a hard thing to fill, and we've been able to get a good group of oral surgeons in so far, and the Northeast Delta Dental and DentaQuist, their subcontractor, are working on other strategies to try to fill in. I think certainly by April 1st, the health conditions that require immediacy will be able to be handled, and we'll be, I think, ramping up the preventative aspect of it. But I think we'll be in a place where we have enough that we'll be given the green light from CMS to continue that. And I promise to keep you informed if it's different than that. We are again on the edge in terms of we didn't have a long time to stand this up, but we think we're going to get there, and that's what I think is reflected here on the report.
Are there geographic gaps in the people who are coming forward to be providers?
There are some geographic things that we need to work on, and I have one of my staff leads is sort of running this, so I'm not as informed exactly what they are, but in terms of just general updates, I know that those are things we're trying to fill out, and that's where I think Northeast Delta Dental and DentaQuist have coming up with potentially some other things to offer dentists to encourage them to sign on.
Would you expand on that? I know I've had this conversation with you a few times and also with Tom Raffio of Delta Dental in terms of incentivizing. What are you doing that seems to be getting results?
Well, I think up to this point, it's been sort of a peer to peer, and it's it's been something that the state and people have had an interest in adult dental to stand up, and there's been a lot of push there. And the second thing is, I think that getting people to understand who are in the dental profession, the extra wraparounds that the worst thing a dentist has is an empty chair. What type of supports are there, and then I think probably the last level is there some economic things that Delta Dental and DentaQuist can offer to encourage some other folks to sign up, and that's kind of they're working through those thoughts at the moment.
Some financial incentivization?
Yep. Some the fee schedule is an enhanced fee schedule, but are there other things to get them to do the enrollment part of it?
Do you have anything? I speak as one who is desperately short of PCPs in our family practice. We just can't find them. And so we're now going to a med school and saying, we'll help you with your tuition, but you owe us, and doing that sort of thing. Is that under consideration for people in dental school?
So we do have the loan repayment program already in place. We also, Dr. Finney can speak more to this. We've, in terms of connecting with the dental schools, I think there was an article I read this past week that talks about there's 100,000 shortage of dentists around the country. So I mean, it is a difficult situation. The other thing is what can be done in terms of teledentistry for screenings, and what can be done in terms of using extenders, if you will, in terms of trying to get to the preventative things. I think those are all strategies that are being looked at.
Is there a dental equivalent of a nurse practitioner?
I think that's a little bit outside my to say equivalent, but there are individuals who can do some of the preventative work that does require ultimately, I think, a dentist to come by and professionally to supervise what was done, but you can extend the dentist.
That'd be a good thing to work on perhaps for future legislation, because we have been authorizing various steps between here and here over the years, and this might be a helpful thing.
Yeah, there are some professions that are trying to advocate that would require professional licensure changes in our state to be able to accommodate.
Okay. Any other questions? Representative Weber?
I'll start with a comment. I know the independent practice of dental hygienists is something that's been an issue ongoing, and I'm not sure the status right now because it's been a while since I was on ED&A, but that has been under discussion for at least the last 10 years or so. But if I may, the question I wanted to ask is, I have heard some feedback, and it wasn't direct to me, so I don't know. Otherwise, I would have had people come direct to you. But in the context of eye care, I know that there was somebody who expressed real concern about how long it took to be reimbursed, like 6 months for eye care. And if you're the only if you're the only practitioner that does it, and you're also having to wait that long to be reimbursed, I'm wondering if it may be outside of the scope of what we're doing here today to talk about those gaps, but I'm hoping that you're building mechanisms in place so that the people who do actually sign up get paid in a timely manner, because otherwise they won't re-sign, and then you'll be in a bigger pickle. So
We do have contractual timeframes in which they have to pay claims, and I know one member of the committee referred to me a practice that I need to. We missed each other because they went on vacation right after, but I do need to finish following up with them. But people shouldn't. I encourage you, if you hear anybody that's not getting paid within 30 days, I want to hear about it.
okay, so 30 days is the basic expectation.
Yes.
Okay,
for
great.
what we
Thank
call
you.
a clean claim, meaning that it's got all the information.
Right.
Representative Edwards?
Thank you, Mr. Chair. We, at the kickoff of this term, I was in on a presentation by a UNH demographer who had all kinds of great statistics about the layout of the demographics in our state. And one of the areas of special interest to me were those pockets where we had a disproportionate percentage of poverty. I'll just go with poverty, and often that poverty was also associated with race or ethnicity. But in a map of New Hampshire, there were like 4 or 5 discernible pockets, and I'm just wondering, as I hear you talk about the gaps in the provider network, if there's any intentional mapping of where our gaps are to where we have potential health inequalities, to ensure that we're doing what we can specifically to to make sure that our healthcare system is balanced and evenly distributed. Do you get what I'm saying there?
I believe I do, and there actually are what they, the Health Resource Services Administration, again, part of the federal, has actually mapped out what they call professional shortage areas. Dentists is one, mental health providers are another. Part of dealing with some of the if you kind of look at, I have a map, I think in the slide deck that I'll review with at your committee on Monday, but just showing kind of where the different enrollment is, and that unfortunately, like where the population is smaller, there tends to be more of those challenges, which makes it difficult for a practice to have the size and the turnover to be, successful. And it's kind of think about managing your mix of who you're going to serve. In other words, it's very hard for a practice that's relying totally on Medicaid to survive, and a practice that has a higher commercial balance of patients. That's people tend to locate where they're going to attract a customer base, if you will, or patient base, where they can balance it out, where they can make a living, if you will, and serving. And it looks like you want to say something about that, Chairman.
Oh, yeah. Seeing the report come across my desk every week, I know roughly how many Medicaid people we can take, even though we are a faith-based nonprofit and this is part of our mission statement. That piece of paper does not give adequate payment to my staff. So I know how much we can do, and we are willing to do more if our reimbursement rate was realistic. So I've said that to just about everybody, including a lot of people who don't care, but you do, and you do, and we need help.
Okay, so I think what I'm asking, if I had an ask, is as you're looking at the gap in your network, if you find a correlation between the gap in the network and these pockets of particular inequality, would you please make it a special effort to report to this committee, with your permission, so that we are aware if we've got a gap and what we're trying to do to proactively manage the gap away in those particular areas where we have disproportionate poverty.
Sure.
All right, thank you.
Thank you.
I have another piece in terms of a couple of pieces that
Mr. Edwards would be happy to pass them. Mr. Williams would be happy to pass them around. He's even buttoning his suit jacket, which is what you do when you approach the bench. Never.
that order. So I just wanted to share some, it's coming around as this color chart I'll talk about in a minute. There's some statistics that the Kaiser Family Foundation puts together about every state and the U.S. on Medicaid. This report was dated October 22nd, October of 2022. And I want to hit on a couple points here. There's also the United States average. One thing I would share with you, and there's also a link here, that New Hampshire as a state has the 4th lowest Medicaid enrollment in the country. So while it feels like, and it is true that we have had a significant increase in enrollment, we're the 4th lowest out of 50 states in Medicaid enrollment. Sort of the percent of population that's low income and the percent of population at the top of the chart there that are covered by Medicaid Today in the country, it's almost 1 in 3 people are covered by Medicaid based on the continuous coverage. In New Hampshire, it's about 1 in 5.5 individuals. The other interesting statistic I think you might find on the bottom right is, and I mentioned this when I was at a Senate hearing this week, is that 70% of the people on Medicaid in New Hampshire are working. That's higher than the national average. And compared to New Hampshire in 2019, I think we're at 65% in 2019. And then, just, I won't go over everything here, but it just, if you want to compare how many, adults we cover, along the bottom left there, there's the number of adults that we cover is 1 in 10. You can compare that to the US, and, children, nursing home residents, Medicare beneficiaries, and probably most of the categories. New Hampshire's probably a little bit less than the national. On the second page, at the top, it kind of is, I think, the top chart, left-hand chart, shows enrollment versus expenditures. And as you would expect, there are certain populations that we enroll that, the older people, the people who are on waivers, we spend more money proportionally per enrollee. It's not necessarily a surprise, but it's just, I think, a nice graph that shows it. And then if you look at sort of 2/3 down on the left-hand side, 24% of the births in New Hampshire are covered by Medicaid. But there's, where we've seen some stress is where that can be 50% in some parts of the state or more. And so that, when you talk about kind of where things are located and stressors, what we've seen, and the legislature did some intervention in terms of approving more money for maintaining maternity care in hospitals and birthing centers.
Can I ask you, in terms of this pie chart, 24% of births, with 4 grandchildren, one was quick, the other was slow, but still it took place over a very brief period of time. Does this mean they were covered pre-birth, postpartum, how long, or just the day they were born, which I don't believe, but
Yeah.
no.
I don't know that this chart does that level of gradation, if you will, in terms of when that coverage kicked in. One thing I would say about New Hampshire is, if you look at, compared to the national numbers, we have more generous eligibility criteria for children. And so, in terms of, taking care of kids, in terms of providing coverage, I think, we stand out in terms of having better eligibility levels than some other states.
Thank you.
And then,
And we're working hard on those postpartum periods.
yes, in fact, I think I have, so the other pages, if you want to just compare to the United States, and if you're interested in any other state, it's easy to send you a link and you can do a comparison. The next grouping are 2 maps. One is the postpartum coverage map. I know that the House took up postpartum coverage. This
Sorry,
map.
where is
I'm
the
not
map?
seeing
We
anything
don't
that
have
looks
a
like a
map. We're
map.
mapless. We don't have a map over here.
Maybe you'll have to find it.
I'm not going to find him in contempt.
There's one more handout.
He and
after
Jack
that, too.
McCoy have taught me the law.
Okay. This one.
I swear those weren't there when I came in.
Sorry, a little out of order here.
Representative Edwards.
Thank you, Mr. Chair. This is just an editorial comment. I realize that the Kaiser Family Foundation is a separate entity, and that one of the things they do is they track politics But for a handout from the government, this on the second page, bottom left corner,
Yes,
associating political viewpoints with support for Medicaid. This is probably inappropriate for a government policy perspective, but that's my point of view. I know you didn't produce it. I'm just warning you that this probably isn't something that ought to be on materials.
okay. And I purposely didn't highlight it because I want to stay with. And the two maps, one is sort of as of February 10th, kind of what's going on in the country in terms of states on that matter. And then on the second map is the Medicaid expansion. There are now 39 states plus DC that have adopted. The latest state is South Dakota, which is in the implementation phase. And this is just because I know you're looking at these issues. I thought you might like to have these two things. Then I sort of a punchline document here, just some observations that I would make. At one at which I began my conversation with saying that, only New Hampshire's the fourth lowest. I gave you the link if you want to check that out and look at that. The other thing that I think is impressive, and if you think of Medicaid not just as a loan, but how it works with the rest of the insurance markets, that New Hampshire ranked #1 in the country in terms of employer-covered insurance, which again I think is a good thing in terms of employer-sponsored coverage. In part, I think when you look at the Medicaid program in terms of what risks it manages and what the exchange manages, I think that helps the health of our market. And then number 3 is we covered that point in terms of the percent of people working. But number 4, is sort of my own personal observation of looking.
Excuse me. Is this a new piece of paper?
Having trouble. So the perspective I would say is you're thinking about it from a policy perspective. Medicaid's part of the I think the functioning of the insurance markets. But when you look at the 1332 waiver that the insurance department obtained to help manage risk, and you look at moving Medicaid expansion out of the exchange and back into the managed care program, that the health of New Hampshire's insurance market, the benchmark premium on the exchange was the lowest in the country. We used to be higher, but I think the combination of policy levers that have been pulled in the state have put us in a pretty good position. And that, in addition, we're seeing a higher percentage of the Medicaid program working. So if you look at things that you'd like to have come out of these different policy levers, I think you can be proud of legislatively and from a department's perspective, both insurance and others, that we're healthcare is expensive. I'm not trying to say it's not, but I think in terms of relative to other states' positions, we have something to be proud about here. More people working than average, lower benchmark premium, and the highest actually employer-sponsored coverage in the country. So,
Could we infer that because there is health care to some degree available to more people, those people are going to be healthier and more likely to have and keep a job?
yes, I think that is an inference I would take from this.
Representative Weber.
One quick question is, you were talking about managing the costs with respect to levers, you said. The one thing I want to be sure of, if we're looking at these numbers and they're real reasons to be self-congratulatory, are we comparing apples to apples in that we are comparing the same level of benefits across the states? Because we know that, there are a lot of programs that some states adopt, some states don't adopt. So I'm just wondering if that discrepancy, or not discrepancy, if that variation has been factored into the numbers here.
In terms of the benchmark premium, yes,
Okay.
that is a national standard in terms of what you offer on the exchanges. There's 10 essential health
Okay.
benefits, and it's a specific.
So this
rate.
is the
So
basic package.
the basic package, and
Okay.
I guess the most common purchased one is what they use.
Okay. Because I just, if what we're doing is saving money because we're not providing the same services, or if we're not providing adequate services, that's not a reason to congratulate ourselves. But if we're comparing to the same bundle of basic services, then
So I think
it looks really good.
Medicaid, when you've seen one state, you've seen one state. There are commonalities, but I think again the fact that we're seeing, comparing 2019 to 2022, and we're seeing more people working, that's a good thing. I can't say it's because of this or that, but it just is, and it's the numbers that are behind that workforce numbers are not numbers produced by Kaiser. They're numbers produced through the Federal Government Bureau of Labor Statistics and one other bureau that part of the census, I think, that produces those numbers. And the only other thing that I had, if you still have time for me, was the chairman asked me to look at rate setting a little bit, and I also know that the chairman of Division 3 wants me to do some too, and I have something here today that there's a lot of work to developing this, but I think the concept was, looking at targeted rate setting versus across the board, and I have some material here that won't answer all the questions. It's a beginning of, I think, the process, but let me just walk through some of this and.
Representative Edwards for a question while the document's being passed out.
So, Mr. Lippman, do you want to introduce this as the 80-20 first cut, or disclaim what we're about to look at?
I would say that the 80-20 is in part, you'll see me raise that a bit, but it's not, I guess, a full 80-20 maybe as you fully maybe envision, but it begins to get to that. It's just in terms of, there's a lot of data work that needs to be done, and I've done as much as I could get out of the various resources I have to do that. And I just,
Thank you.
what I want to do today is present sort of some concepts and share some data. So if slide 1 is sort of, I guess, my overview of what you would expect to see in rate setting in terms of just rates in general. That, generally Medicaid rates, where possible, are usually expressed as a percentage of Medicare. Medicare being a system that's intended for a reasonably efficient provider to cover full costs. Medicaid generally covers a percentage of full costs. When it doesn't cover variable costs and only covers a little bit of full costs is when, as the chairman talks about, you have to manage how many patients you accept or accept at all. And then commercial rates are typically for facilities are 2 times Medicare. For physician services, about 1.5 times that, though that relationship of 1.5 times doesn't necessarily follow through when you get like at physical therapy, ambulances, and other things in our state. And that, within the Medicaid program, to cover all the drugs and everything that we have on our charge master, if you will, there's 13,000 codes. But using the 80/20 rule, and if you jump to, let's see, the last, let's see, yeah, actually,
For those of us who are ignorant, could you just explain what the 80/20 rule is?
sure. The Pareto principle is basically that typically 20% of something can describe 80% of what you're going at. And so, in terms of the 13,000 codes, as an example, in for example, professional services, that about 100 codes explain about 80% of our spending. Or in waiver services, maybe 142 codes, billing codes, represent about 80% of our spending.
Thank you.
And, I don't think we have time to go through sort of a code level, but
Do you know that my dog giving comfort to scared people in the waiting room is not a billing code because we looked?
I believe you. And other things. Then the second slide, I guess, is is sort of like how, when you're doing targeted rate setting, how you might go about looking at it. So, if I sort of put it in steps here, is that I think the first thing you look at is how does the rate that you're paying compare to Medicare, or if it's a cost reimbursed services, how does it compare to allowable Medicaid costs? That's, I think, the first thing, but that's not the only thing you have to look at. Again, I think we also tend to look at other states' rates to see what they're paying, but that sometimes doesn't tell the whole story either. Then where it starts to come into a less more subjective, because we don't have hard data on this, is, are we seeing access issues? For example, in private duty nursing, we're only able to fulfill 60% of the hours that are assessed by a physician, as an example. Based on the staffing that's available, we've all read a lot about the mental health crisis in terms of how long it takes to get an appointment if it's not a crisis situation. Then a fourth factor is the number of Medicaid patients, or the percentage of your revenue or percentage of your patient base that you can afford to serve. Then looking at the financial status of the provider type, some providers have a little bit more, that they're less dependent on Medicaid, or maybe larger and get certain economies than others. I described, for example, I think some provider types are like the subsistence farmers. They're just barely making it. There's no real reserves there. And then I think the other factor that we've talked about today is, is there the workforce shortage issues are, and so I think you have to look at these issues together, sort of a holistic approach of what you're trying to accomplish.
Representative Edwards.
Thank you, Mr. Chair. I'm looking at step 4, and I'm just trying to think through the rationale of why it's a concern of Medicaid to look at a percentage of revenue from both a Medicaid and an uncompensated care perspective. Is it our obligation, is it the state's obligation to worry about managing the uncompensated care levels at a given facility?
So it comes into play indirectly, in the sense that if a provider serves exclusively or near exclusively Medicaid, and they have a lot of uncompensated care, their ability to stay around, because they're not getting full cost on anything. And if we're depending on that provider type, is the issue.
Is to what extent is the amount of uncompensated care a local provider decision? Are they mandated to provide 100% of the care under their uncompensated care program, or I'm just trying, it's been so long I looked at uncompensated care. I'm just trying to remember the flexibility the providers have in accepting that.
So some of it may be just better described as bad debt, like person has a high deductible plan and, they owe $100 or $1,000 or $5,000 on a bill, and, do they make that payment? And, so I think that it's again, in, our nursing home reimbursement and our hospital reimbursement in the state, we do take into account directly uncovered costs. And so I think we do have an interest, but ultimately the interest boils down to, can the people, are we providing a compliant program where people have access to the benefit that we're paying a premium for through the insurer? But that I think is, like substance use disorder provider. One provider, for example, might accept all comers, and if that provider is going to go down the drain and we're going to lose complete access to, say, high level substance use disorder services, we do have to take an interest in that to ensure that people can continue to be served. It's not, as I say, it's not like a mathematical calculation. It's sort of a factor in looking at the rate that, when you're targeting rates, what you should potentially do.
I know in my facility, we look at bad debt and we try to look at it as compassionately as we can. And there's very good reasons why very good people sometimes can't pay their bills. And we very often will carry those people to the degree we have good insurance people paying.
Right.
We also have the right to discharge a patient in 30 days. You can come to us for the next 30 days, but after that 30 days, you're out. You are not our patient. And we've had to do that rarely. Other people, other facilities may have a different standard of when they boot people for bad debt.
Some can't at all.
Some can't, yeah.
The third page in is, again, in terms of the time frame I had to sort of work on things, working with some existing data, is looking at some major groupings of codes in terms of what percent of Medicare based. This is not managed care data. This is just what we're paying under fee for service. What percent of Medicare are we paying? So generally, you would hope to see something in a, let's say, a diversified provider. I think it's between 60 and 80% would be considered that you're covering variable costs and some of fixed costs. In some areas, you'll see we pay more than that, and there's reasons to do so. But it's in starting to look at what categories where we may need to look at certain things. And the bottom one I'll explain in a moment. But this is kind of where we are today in terms of looking at our fee-for-service schedule against the Medicare fee schedule. You can see in a lot of areas, we're below 60%. And the bottom one is really, again, it's a very small area, and it's where that number is high is related to supplies, not on ambulance services. I'll show you ambulance in a little bit. But again, this is only a very small number, and we're only talking fee for service here. And in part, sometimes because, there've been years, in some cases decades, between being able to adjust fee schedules, that some things get out of whack, and being able to do a targeted approach allows us to address some of these issues. Going to the fourth slide, there are some services we pay on a cost basis, and and these the numbers that we're looking at here are don't include any supplemental payments or additional payments made outside of the payments here. But basically, this is a group of facilities that are based on a cost basis. Yeah, you might, House members in particular might zero in on nursing facilities, county providers, that we make two additional payments on top of what is 48% of cost is what the daily rate reimbursement amounts to, but we also make, based on the provider tax, that the NFQA tax, that's assessed, we make a payment, and then we also make the pro share payment on top of that. Again, when you look at, the county providers are serving almost, approaching 80%, private providers 61%. The private providers do not get a pro share payment. And then state-owned facilities, we're trying to get it up to cost is basically what you see there. There are some costs that aren't allowed. The next slide is just an example of something that, I'm sorry.
Yes, Representative Weber.
I'm just trying to, this is an area that I just am not at all familiar with, so I hope you'll pardon my ignorance, but I'm looking at the fact that the county providers are at a base rate of 48% of allowable cost. And I'm wondering why there's so much difference between that and the private facilities and what that all means, because I'm really ignorant in this area. And if it's just me, I'll back off and have that conversation outside of everybody else's time. But we're all pretty concerned about our county nursing homes.
Yeah. County facilities, right? I think we would recognize often are the last resort in terms of accepting a patient. In many instances, the mix of people that they have to accept or do accept may have a higher intensity of need of service. It could be not necessarily that they're sicker, but they may need more supports. Yep. Right. So then what the 48% represents is the daily rate. So if you're accepting patients that are more costly to serve, if you will, the cost that the county facilities have, you would expect that they would cost more and that the rate would be less efficient. So then what we do for all nursing facilities, we try to make up some of the difference between costs through the tax program and the extra match that we draw and pay out to all facilities. And then for the counties, because they have that sort of adverse situation, we make the pro share payment on top of that. So I didn't have time to calculate what that all would look like, but that's just to show you why in one instance if we didn't take into account the payer mix of the counties and do something extra, we wouldn't have probably county nursing facilities.
No, I understand the mix. I just didn't understand how this statistic related to it. So thank you.
The next example is related to private duty nursing and licensed practical nurses in the state plan. In terms of, we had some concerns expressed to us about, and as I mentioned to you, we have trouble meeting all the hours that patients have been assessed for. And, we did some comparisons with other states here, and this is probably something that we did probably about a year ago. And when you look at the sum total of it, when we compare ourselves to like Vermont and Maine and Rhode Island, we're pretty competitive there. But we're also hearing from that provider class that they're stressed in providing services, and we see a big gap in coverage. Again, this is sort of a judgment call in terms of targeting rate increases, because if you're not providing adequate home care, people end up institutionalized, which is a much more expensive way for the state to pay for, meeting their needs. So it's it's a balancing act. This is sort of an unresolved one at the moment. The next one is ambulance, and this is one where the legislature approved moving the rates from. You look at the blue heading columns, the rates that existed prior to the legislature's actions, that we were running, depending on the service, as low as 22% of Medicare, and up to 38 was the high. Here, the commissioner and I have received phone calls that nursing homes and hospitals are having difficulty getting either patients to appointments for medical appointments through and also transfers between hospitals. Just this week I got another complaint that from 3 nursing facilities that the provider that's been helping them get patients to hospitals, that they're basically saying to them, we can't serve you anymore. We don't have enough staff to do it. We've got to manage our payer mix, and we're going to do something else. Then, so the 50% increase is in the orange, kind of where we stand today. But, again, when you look across at other states, we're still lagging there, and it's an issue. I think that when patients can't get transferred, those costs get passed down to municipalities who have to maybe use their fire department to transfer, or they have to pay additional money. It's an issue that I think we all need to be concerned about. So again, I think workforce shortage, inability to meet patients' needs is something that we're definitely seeing. Then I think the last example I wanted to share with you was hospice care. And this is one where we're paying slightly more than Medicare, and we're kind of pushed into that. And that maybe it's not a bad thing because of concerns about people who need hospice treatment, but having to apply across the board sometimes leads in a result where maybe part of that money could have been better used somewhere else. And so, and then the last 2 pages are some work that started to do in terms of looking at where our spend is in paying claims. This is only claims for comparing 22 to 19, just 2 years that we have sort of complete information on. So the pre-pandemic year, calendar year 19, and sort of coming out of the pandemic 22, in terms of where the dollars are in terms of when we need to make rate adjustments. I do have some other exhibits that are I think I'll save to when I get to fiscal committee, that looks at that 80-20 kind of concept in terms of which codes get to the big account for a large percentage of the spend. And as I said, I think in the professional category, I can fit them all on one page, pretty small, get up to 80%. And on the waiver programs, I don't even need a full page, and I can get to 100%. So I think there's hopefully some of this information is helpful. I know it's not all you want. It's not all that I can produce. It's just what I could produce in the time frame. Sorry.
Yes, Representative.
Okay, thank you. This is far more than we had just a few days ago when we were hearing 3.1% across the board. So now I think we're starting to think here, and this is good. So is one of your takeaways that maybe if we're looking to rebalance the 3.1%, and I mean, we could just make it bigger, right? We could make it 5.1% theoretically, but if we kind of wanted to stay within a 3.1% pot, and we wanted to redistribute from one side of the pot to the other, did I hear you right to imply that maybe our hospice services could help fund or reallocate from hospice into some of these other categories without doing damage to the hospice?
I think just purely looking at it as a rate issue, if Medicaid is generally supposed to just not pay more than Medicare, the answer, I guess, would be yes. I don't know enough, haven't spent enough time to understand the whole hospice situation and how it fits with home care agencies, which may be stressing on another side.
Follow up.
So, okay, so pretending for a moment, I'm not holding you to it, but just for the purposes of the conversation.
But I think you're getting
So,
to it.
so if we find that hospice could potentially be a place where we could free up some money to reallocate somewhere else, which of these categories, because you have about 8 slides, do you think is the most critical that we may want to fund more on a more urgent basis?
Well, I think in terms of looking at it from the Medicaid program perspective, I think probably mental health issues, substance use disorder issues, ambulance issues.
Is that one of the slides? You're saying words that I don't think we just reviewed on any of these slides.
They're the professional services of that are that when we get down to a code level in that grouping, you'll see
Could you refer to a page? Tell me what page?
it's not on a page. And what I'm saying is I gave you a broad category.
Right.
If we drill down to the code level, like you can look at those types.
Is that the kind of information on the other 2 sheets that you're bringing to the Division 3?
Yes.
Thank you.
Thank you.
And I think I've overstayed my welcome, but I know there's one more report that
We will decide that, sir.
Okay.
Thank you.
Well done.
Thank you. I think you had 149 that you also wanted to get
A
reported
little bit,
today.
yeah. We can do 149 a little bit, yeah.
Okay. Thank you for the opportunity and appreciate the chance to share this. Thank you for so much time.
Do you have a copy? I don't.
No, Johnny Williams, you know the button you called this from up here.
Wait, let's use my. Hello. My name is Karen Hebert, again, from the Division of Economic Stability, and I just wanted to actually take 15 seconds.
Could you be a little closer to the microphone, please?
Thank you. I just wanted to take 15 seconds and introduce to you my new Deputy Director for the division, Tina Cabana. I just wanted to
Would you spell that, please?
Cabana, Tina, Tina.
Welcome. And you are Deputy Director of
The Division of Economic Stability.
Stability. Good. Welcome.
Thank you.
Good morning. My name is Dawn Tierney. I'm a Medicaid Policy Administrator for the Division of Medicaid.
So we are happy to provide you with this, would be the final report in accordance with Senate Bill 149. And happy to answer any particular questions you may have about that.
We'll give it about 30 seconds so they can finish and then yes.
May I have a question, Mr. Chairman?
Representative Edwards is first, and then after that,
Oh, okay.
and you may go.
I just want a one sentence definition of what the term spend down means.
That's when an individual has too much income to qualify for, like, for a granted advantage. So they have to then incur medical expenses before Medicaid will, and once they meet that income level, Medicaid will then begin to pay for any claims. They're in fee for service, and the spend down will generally have to be met every month unless they're on a 6-month period.
Representative Weber.
Well, I'm asking this because I know that the Honorable Ken Snow would want me to. Does this mean that how far have we progressed towards his goal of upping the limits at which the spend down has to start, or at the upping the limits at which the spend down ends, and making it easier for the people, both the people who are subject to the spend down as individuals, and in particular the mental health centers who have to eat the amount that can't be paid for until the spend down happens. I know his objective was closing that gap, and I'm wondering how this report fits with that.
So this report doesn't really have anything to do with increasing the, we call it the PIL, the protected income limit. Effective January 1st of this year, the income limit for a household size of 1 increased to $888, where prior to that it was $591.
Okay.
Any other questions from the committee? Seeing none, thank you.
Well, I actually do, I think.
Seeing one.
Thank you.
Yes.
I'm just trying to absorb this. So what I think I'm reading here is that more than half of the people who are subject to the spend down don't have to actually submit the medical expenses every month. How do you track that?
So what this is actually saying is due to the continuous eligibility enrollment during the COVID-19 federal public health emergency, they don't have to submit their bills. We do it systematically for anybody who met their spend down on or after March 18th of 2020. But once that continuous eligibility requirement ends, then they will start have to submitting the bills for the spend down.
Okay, well, that answered my follow-up question. Thank you. Darn.
Not everyone's favorite program, that's for
I
sure.
was going to say, and we miss Representative Snow a great deal
We
because
do.
he kept his eyes firmly on that
Yes,
particular
yes.
ball.
Yes, and I'm glad to report that we were able to get it increased for helpful meeting his objective.
Thank you.
Seeing and hearing no further questions, thank you so much.
Thank you.
Just a word to the committee. Our next meeting is March 24th, fourth Friday of the month at 10 a.m. We will have a report from the interim commissioner and from Mr. Lipman. We will be given reports that we need to hear. And the final item is one or more things that the committee would like to hear. This is the opportunity where we might have a question about something, and with advance notice, we can ask the relevant department people to come to be with us. And this is something that I work with Attorney Williams with, is shaping the next agenda. So if you've got some ideas, please give them to me. You see, he can do many, many things besides pass out paper, and does them well. And we shape the agenda each month. He tells me what to think. I think accordingly, and we're both happy. So let me know. And yes, Senator.
I want to go back and revisit the quorum for this meeting. I pulled up the RSA while I was sitting here. It's 3 senators, 5 House members, plus 2 alternates, so that would be 8 members, and therefore the quorum would have been 5. Okay. If I'm incorrect, I'm sure that the chair will inform me.
Thank
I
you.
think you've
I had forgotten
I think you've informed
the
the
issue
chair,
of the
Senator. Thank you.
I was just taking the number, the raw number, so my mistake.
Meeting is adjourned.
As a follow-on to that, Mr. Chairman, I note that on the website, we only have 1 member who is listed as an alternate. Well, I know we have 2, and so we need to figure out. Well, there are 10 people named, and I think that, and Senator Gray is right.